Mm. Greetings. Starting soon. Greetings.
Hola, John.
Hola.
Hello, John.
Estoy hablando con Ip ahora. Dame un minuto, espera.
Sí.
Sí. Sí, él está dando charlas en Latinoamérica sobre cisternostomía. Si necesita esto en Latinoamérica. ¿Cómo está, Víctor? Tú pareces muy bien astrapado. ¿Cómo se dice en español? Well dressed. Bien vestido.
Bien vestido.
Okay. Sí. ¿Cómo estás?
Bien, bien, un poquito mejor. Ya ves que tuve gripe.
Sí, ya se entiende. Ya se entiende. Es obvio cuando hablo contigo, tiene un poquito gripe.
Sí.
Oh. Y déjame obtener mención. Ok, sí, estamos aquí. Mira que yo voy a mostrar. Para tú sientes mejor, porque hay muchas personas en chinesa mirando. Okay. ¿Tú puedes ver?
Sí, claro, sí.
De la
Sí.
última, 3,300. Va a empezar otra vez.
Sí, la última, no, la primera fueron casi 1300.
Oh, sí. 3,000. Y déjame ver si hay otro. Pero hay mucho más en ¿Tú puedes ver en su computador?
No.
Mention.com.
Ajá.
Si tú quieres ver simultáneo,
¿En dónde viene?
yo voy a escribir en chat. Okay.
Ahí se ve ¿cuántos están entrando?
Tú puedes ver, ¿verdad? Mention.com.
Sí, a ver, estoy viendo aquí, es medition.com.
Sí, medcion.com.
Medición.com. Medición.com.
Sí, sí.
Ajá, sí. O sea que ahí viene la información.
Jesse, ¿está allá? ¿Puedo oír, Jesse? Yo creo que Jesse está aquí.
Sí. Hello, Jesse.
Okay.
Hello, Kepler. Nice to see you.
Buenos días, profesor.
Buenos días. Buenos días. Mucho gusto de verte.
Ben está aquí.
Binshu is here.
Sí.
Hello, John. Hello, Victor.
Hey, good morning. Good morning.
Hello,
Hi.
Binshu. How are you?
Hi, how are you? Fine.
Very nice to see you.
Nice to see you.
Ben, Victor is making us look underdressed.
Yes.
So well dressed.
Yeah.
So how you been? How many bypasses today?
Today I have let me nine.
9?
Yeah.
Well,
And the 3 endovascular treatments.
oh, okay.
Mhm.
Now when the residents prep the patient, how far do they go before you walk in the OR and take over?
Yeah, just they can finish most of the things.
Oh, okay.
Only the bypass.
Okay, only the bypass and then you move on to the next patient.
Yeah.
Okay.
Yeah.
That's the crucial part.
Yeah.
Yeah. Okay. And they basically prep it and get it ready and etc. That's great. What do you think of that, Victor?
How
8 or
many
9 a day.
how many bypasses have you done in your career?
Oh God. 10,000.
By now?
More than 10,000?
No. Yeah, very close to 10,000. It's 9,000 and maybe 700.
Wow.
Yeah.
Do you film all of them or no?
Mm-hmm.
Do you film them? Do you take videos of them, of all your talks?
Yes.
Oh, wow. So
Yeah.
all 10,000 are in Mentian? Are they in the archive?
Yeah.
They are in Mentian. Oh, okay. Okay, yeah, Yuha is speaking next week, next Sunday.
Yeah,
I think I sent
you
you
told
that.
me.
Oh, okay.
Victor, what's the time at Mexico City?
It's
Now?
7 o'clock.
Okay.
5 minutes before
Okay.
7 o'clock.
Okay.
Yes. And there in China?
8 p.m.
8 p.m.
Almost. Yeah.
The time changes, right? Sometime it got me confused once where there was a time change in China. Is there a time change? No, it's
No.
always the same?
Yes, we
Oh,
don't
okay.
use, sometimes we, maybe 20 years ago, we used some summertime, but now it's just a routine.
Oh, okay.
Yeah.
Now, Shanghai is open now completely? Shanghai is open?
I'm not think, I don't think it's completely opened, but
Oh, okay.
mostly, yeah.
People are still wearing masks.
Yes,
Yes.
because
never
there are
stopped that,
some
right?
different mutations of the virus now.
Okay. Yeah,
Yes.
mutation.
Mhm.
Is that a big problem in China? That mutation?
No.
No.
It's controlled very well, but it caused some problem in, I think, in Australia and in India.
Okay.
The BA 2.75 it's called the new mutation. Yeah.
I think they're getting better containing something like
Yes,
that. Get
yes.
on it right away.
Mhm.
We're learning. It looks like it won't go away.
Yeah. Yes.
Like we all wish it would.
Mhm.
Okay, we start in a few minutes. Hello, Jesse. Good morning. Can you hear me okay?
Hi, Jerome. Yes, I can hear you perfectly.
Yeah, Victor, yeah, we're sorry we couldn't get you the files.
No worries.
But if you talk to Victor, you can tell he's got the flu. Hey, Victor, say hi to Jesse.
Hello, Jesse. Thank you.
Hi, Victor.
Thank you very much for
You're very welcome.
for the great job you are doing.
Oh, I've also learned a lot from your lectures, so it's mutual beneficial.
A two-way. Now, Victor, what were you saying to me? You were going to try to speak slower to help Jesse?
Next lecture, I can send you one day before. I try to do that, but I had some difficulties to make that. It would be very nice if you can send me an email.
Yes, I can put my email address in the chat box.
Yeah, I got it too, Victor.
Yeah.
And also I got the platform that she sent to you, send big files, unless you have a platform yourself. And I have some ideas. But anyways, we have some time to prepare for next week. We'll get it to you, Jesse.
Yeah.
Don't worry.
No problem. Yeah.
Okay. You got her email, right, Victor?
Yeah, I put in the chat 2 emails.
Yeah, you got those emails, Jesse, right?
Okay.
Yeah. That's my email address.
Thank you.
You're
Now we're
welcome.
prepared. So. Okay, Victor, you ready?
Yes.
Okay, here we go, Jesse. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett of Neurosurgical TV. We have the honor of hosting the third in a series of Neuroanatomy, specifically designed for the Chinese neurosurgery audience. We would like the Chinese neurosurgery audience, if they have any comments or questions, to please just submit them to the interpreter, Jessie, and she'll pass the questions on. And I'd like to thank Ben for helping us put this together. Hello, Ben. How you doing?
Hello, John.
Okay.
Hi, Victor.
Okay, good to have you here, Ben. Okay, Victor. Yeah, I've known Victor for a long time. He teaches a lot, neuroanatomy. He's dedicated, as you'll see from his illustrations and models. He lectures extensively in Latin America in Spanish, and today he's going to lecture in English. It's going to be translated by Jesse and Takashi into Japanese. So I'd like to welcome Victor. Hello, Victor.
Thank you, John. This is a real honor for me to be here with all of you. Thank you to you, John Bennett. You are doing a very great job around the world, and thank you, Binshu. It's a honor to be with you, world champion in bypasses in vascular neurosurgery. It's amazing, your job. Thank you. Today, I'm going to talk about the circle of Willis. Let me share the complete screen.
Oh, yeah, I'm sorry, Victor.
I think
yeah, I'm
not
sorry, Victor.
ready.
Let me get through there.
Ready?
I'm sorry, Jesse. Let me just get the sound right. Jesse, can you hear me okay,
Yeah.
Jesse?
Yes, yes.
Yeah,
I
we're
can
getting
hear
your
you.
sound on the webcast here. Let me. Okay, there we go. I'm sorry, Victor. Go ahead.
Okay. We are going to review some neuroanatomic aspects of circle of Willis. As you know, circle of Willis is formed by arteries around the center of the brain, in the inferior aspect of the brain. It has an anterior part and posterior part. The anterior is formed by both anterior cerebral arteries, A1 segment, left side, right side, and anterior communicating artery. And posterior part of a circle of Willis is formed by the posterior communicating arteries, one in the left side, one in the right side. Posterior communicating arteries are arising in the posteromedial part of the supraclinoid carotid artery. This posterior communicating artery goes to the posterior cerebral artery. Here we have the basilar artery, bifurcation of basilar artery, and here we have P1, P2. Excuse me, John?
I'm sorry, Victor. Are you hearing that audio?
Yes.
Yeah, I can't, Jesse. I can't. I keep getting your audio, Jesse. Can you hear me, Jesse?
Yes, I can hear you.
Yes, John.
You know, even though I'm taking her off, I'm still getting her audio. Jesse, can you hear me okay?
I can hear you.
Yeah, Jesse, I'm
There is
hearing
no
you. I'm
problem.
hearing your
Yeah, I can
translation.
hear you.
Yeah,
Okay.
so I'm gonna mute you right now and let's see if it works, okay? Okay, I muted you.
Okay.
Sorry, Victor.
Then we have a posterior communicating artery joining with posterior cerebral arteries. In this case, we have a posterior communicating artery that has a diameter bigger than the P1. This is known as posterior fetal variant of posterior communicating artery. So here we have the circle of Willis. Optic nerves, infundibulum, and mammillary bodies in the hypothalamus. This video is to watch the circle of Willis and anterior communicating artery. Here we have some arachnoid Here we have basilar artery, posterior cerebral arteries, and dissecting the arachnoid membrane, we can see A1 segment in the right side, A1 segment in the left side, and anterior communicating arteries. In here, we can see also the recurrent artery, this recurrent artery of Hübner. I'm going to retract to displace this orbitofrontal area of left frontal lobe. In that manner, we can see the A2 segments and anterior communicating artery. So here we have the anterior aspect of circle of Willis and posterior part of circle of Willis is this one. As I showed you last lecture, these are some branches in A2. A1, left side, A2, recurrent artery of Hübner, and also in the right side. So, posterior communicating artery forms the lateral boundary of the circle of Willis, arises from the posteromedial surface of C4, approximately midway between the origin of the ophthalmic artery and the terminal bifurcation. It sweeps backward and medially below the tuberous cinereum, above the sella turcica, and slightly above and medial to the oculomotor nerve to join the posterior cerebral artery. So here we have the origin of posterior communicating artery. Here we have the left side and the right side. Here we have the supraclinoid carotid artery, optic nerves, infundibulum, and here we have the mammillary bodies. So in this side, we can see the basilar artery, superior cerebellar artery, and posterior cerebral arteries in the right side, left side. So between these arteries, superior cerebellar and posterior cerebral artery, we have the third cranial nerve. Always, we are going to see the third nerve emerging from the brain stem between these arteries, superior cerebellar, inferiorly, and superiorly, the posterior cerebral arteries. And here we have posterior communicating arteries that forms the lateral aspect of the circle of Willis. So here we have both posterior communicating arteries that have a diameter these are hypoplastic variant. Dr. Roton used to say that when this artery is lower than 1 millimeter, is known as hypoplastic. So here we have both of them hypoplastic variants of posterior communicating arteries. Other arteries that we can see here is the middle cerebral artery, lenticulostriate arteries, and a trifurcation. This is not a bifurcation. This is trifurcation. 3 branches coming from middle cerebral artery. The posterior communicating artery originates from the posteromedial wall of the supraclinoid internal carotid artery, passes posteromedially below and laterally to the tuber cinereum above the sella turcica and oculomotor nerve, joins the posterior cerebral artery, the terminal branch of the basilar artery. In most cases, the posterior communicating artery has a larger diameter in children than in adults. It has been described that it gives rise to different branches, from 2 to 10. In our studies, it has been found that it originates an average of 4 to 10 branches, and 30% have been found to have a fetal pattern. It was observed that the posterior communicating artery, even though it is hypoplastic, can give rise to multiple branches. These branches supply the medial third to the anterior perforated substance, mammillary bodies, posterior hypothalamus, lateral and inferior optic chiasma, optic tract, ventral portion of the thalamus, subthalamus, and tuber cinereum. The premammillary artery. This artery is the largest branch that arises from the posterior communicating artery. It enters the floor of the third ventricle in front of or beside the mammillary body, between the mammillary body and optic tract. There are commonly 2 or 3 branches terminating in the premammillary area, but only the largest branch is referred to as the premammillary artery. I'm going to show you a very nice video about this premammillary artery in the next slide. Now, we should know that premammillary artery has also been referred to as the anterior thalamo-perforating artery. The premammillary artery most commonly originates on the middle third of the communicating artery, but can also arise on the anterior or posterior third. It supplies the posterior hypothalamus, anterior thalamus, posterior limb of the internal capsule, and subthalamus. Here we have anterior cerebral arteries, posterior communicating arteries, and look at here. Here we have the premammillary artery that is the largest branch coming from posterior communicating artery. This video is very nice because we can understand much better the trajectory of the premammillary artery. The posterior communicating artery is this one, but this artery broke, was separated from posterior cerebral artery. And you can see also that this artery is hypoplastic. And this is the premammillary artery. Let's go to see a very nice dissection to understand this premammillary artery. Here I am doing a dissection in the hypothalamus. I am resecting gray substance. Here, I am cutting the thalamus. Now, we can see the thalamus, hypothalamus. Here we have the fornix. And as I continue dissection, we can see this artery that is going to the anterior part of the thalamus. Continue with dissection of hypothalamus. Here we have the mammillary body. And look at here. Here we have the posterior communicating artery and the pre-mammillary artery coming from this posterior. Here we have a very small branch going to the mammillary body. And look at this. Here we have the pre-mammillary artery going to the hypothalamus, to the mammallar body through this small branch, and then going to the thalamus. The posterior part of circle of Willis. So here we have posterior communicating artery in the left side. We can identify this artery because its origin is in the posteromedial aspect of the supraclinoid carotid artery. But what's happening in this case? So here we have a very small P1 artery, posterior cerebral artery, and here we have a fetal pattern of posterior communicating artery. This fetal variant of posterior communicating artery give rise to the most important fluid to posterior cerebral artery. And in the other side, we have a normal aspect of P1, but a hypoplastic variant of posterior communicating artery. Here we have the posterior communicating artery. So the bifurcation of the basilar artery and superior cerebellar arteries. Remember that the third cranial nerve is going to be between posterior cerebral arteries and superior cerebral artery. P1 segment. The P1 segment, also called the pre-communicating segment, extends from the basilar bifurcation to the junction with the posterior communicating artery. A fetal configuration in which the P1 has a smaller diameter than the PCOM-A and the posterior cerebral artery arise predominantly from the carotid artery occurs in approximately 1/3 of hemispheres. A normal configuration in which the P1 segment is larger than the PCOM-A is found in nearly 2/3 of hemispheres. This is a normal configuration. A few hemispheres will have a posterior communicating artery and P1 of the same diameter. A fetal configuration may be present on both sides. So here we have a normal pattern. Let's go to see this video. So here we have the small branches coming from posterior communicating artery, and other branches coming from P1. Here we have the thalamo-perforating arteries and some mesencephalic perforating arteries. Thalamo-perforating arteries. Posterior communicating artery. These pictures could be a little difficult to interpret, but if we go to the anatomic knowledge about, for example, about the origin of this third cranial nerve. So first of all, we can see this oculomotor nerve, and then we can see the mammillary bodies. So now we know that we are in the posterior aspect of the circle of Willis. What are we watching now? Okay, let's go to this artery. This is basilar artery. And these are superior cerebellar arteries. So here we have a P1 of posterior cerebral artery in the right side, and in the left side, here we have the P1 in this left side. So I want you to watch this hypoplastic P1 in the right side. Look the fenestration of this hypoplastic P1. So although this artery is hypoplastic, look how many branches are coming from here. In this picture, you can see just 1, 2, or 3. But let's go to see next picture. Look how many branches are coming from that artery. There are maybe 10 or 11 branches coming from this P1 hypoplastic. So this is amazing. Although this artery is hypoplastic, it has the origin of numerous branches that go to the mesencephalic area of the brain stem. The posterior part of circle of Willis is one of the most difficult sites to approach surgically. The complex series of perforating vessels surrounding and arising from it, and its intimate relationship to the extraocular nerves and upper brain stem. Its branches are exposed in surgical approach to the basilar apex, tentorial notch, lateral and third ventricles, inferior temporal. Let's go see this video. So,
arterias perforantes.
Here we have perforating, thalamo-perforating arteries coming from P1 and also from posterior communicating artery. Third cranial nerve, this is posterior, this is anterior, mammillary bodies. But we can see in here another fissure. So here we do not see a posterior communicating artery. So this is an incomplete circle of Willis. Let's go to see again. I think this is very important to watch, to understand. The thalamo-perforating arteries, basilar bifurcation, third cranial nerves, interpeduncular fossa, mammillary bodies, the vascularity complex of this region is spectacular. It's amazing what we can see in this region. Sometimes you can only find a few arteries, but other times you can see a great number of these perforating arteries. So here we have another video to watch this posterior aspect of circle of Willis. So in here we have basilar bifurcation, P1 in the left side, posterior communicating arteries, in the right side posterior communicating arteries, P1, P2, and thalamo-perforating arteries, and also some mesencephalic perforating branches. When we inject silicone in these arteries, we can differentiate the arachnoid. This is arachnoid from a real arteries. So that's the advantage in an injection of these arteries. Superior cerebellar arteries, P1, right side, posterior communicating, left side, thalamo-perforating arteries, and the pedunculum. The relatively constant branches arising from the P1 are the thalamo-perforating artery, which by definition enters the brain through the posterior perforated substance, the medial posterior choroidal artery directed to the choroid plexus in the third ventricle and lateral ventricle, the branch to the quadrigeminal plate, and rami to the cerebral peduncle and mesencephalic tegment. Here we have a sagittal cut, a sagittal view of this amazing part of the brain stem. Here we have hypothalamus, the thalamus, the quadrigemin plate, pineal gland, mesencephalum, and here we have these amazing arteries coming from P1. Look, these small branches going to the mesencephalum. Fetal configuration. This configuration is in which the proximal PCA is small, as in this case, and the posterior communicating artery provides the major supply to the PCA and is larger than the P1. So, basilar artery, look, the third cranial nerves beside in the brain stem, posterior perforated substance, mammillary bodies, and as I told you, this third cranial nerve is between posterior cerebral artery and superior cerebellar artery. So the artery found superiorly in relation with the third cranial nerve is P1. And this is P1 segment with a very small type. And in the other side, we have also a P1 smaller than the posterior communicating artery. So here we have two fetal configurations of posterior communicating artery, because this provides the major supply to posterior cerebral arteries. But what's happening with the bifurcation? Bifurcation is this or this. So I think that bifurcation is this one, because this is the P1 segment. This artery is going to joining with posterior communicating artery. And the other one is thalamo perforating branches. A hypoplastic arterial segment is defined as one having a diameter or 1 millimeter or less. This is posterior communicating artery, and its diameter is smaller than P1. No, this is P1. This is posterior communicating artery, a fetal configuration. But this is a very large P1. Look at this. The distance between posterior communicating artery coming from supraclinoid carotid artery and from the basilar artery. these are some variants in the some variants of some brains. The posterior part of circle of Willis send a series of perforating arteries into the encephalon and midbrain. Some of the perforating branches arising from the upper part of the basilar artery overlap with some of those arising from the posterior circle. Here we have P1, left side, P1, right side. Oculomotor nerves. And we can see also the damage that occlusion of these vital perforating vessels during tumor or aneurysm surgery include visual loss, some aesthetic disturbances, motor weakness, memory deficits, autonomic imbalance, diplopia, alteration of consciousness, abnormal movements, and endocrine disturbances. The posterior circle is one of the most difficult sites to approach surgically because of its location in the midline, below the third ventricle, the complex series of perforating vessels surrounding and arising from it, and its intimate relationship to the extraocular nerves and upper brain stem. Let's go to see this other video. So look, the oculomotor nerve. Inferiorly, we have the superior cerebral artery. Superiorly, this P1. Okay. This is posterior cerebral artery. And I couldn't see a real communication between posterior cerebral artery to posterior communicating artery. Practically, in this case, posterior cerebral artery was arising from supraclinoid carotid artery and not from posterior circulation. Thalamo perforating arteries, P1 in the left side, posterior communicating artery, and P2, posterior cerebral artery. The posterior cerebral artery P1 segment is also known as pre-communicating segment. And here P1, left side, P1, right side. Here we have a video in order to see this beautiful region. I could part of the brain stem and could also the basilar artery. I separated also the posterior cerebral artery in order to see another branches like this third cranial nerve, left side, third cranial nerve, right side. Posterior communicating artery in this case. And here we can see these branches. The supratentorial arteries include, this is like a small review. The supraclinoid portion of the internal carotid artery and its anterior and medial cerebral. Ophthalmic posterior communicating, and anterior choroidal branches. The components of the circle of Willis, which in the posterior midline includes the basilar apex, and finally the posterior cerebral artery. The origin of all of these arteries is located deep under the center of the cerebrum, and their proximal trunks are relatively inaccessible because they course in deep clefts like the sylvian or interhemispheric fissure, or in the basal systems between the brain stem and temporal lobe. Optic nerves, chiasm. So in a few times we can remember the anterior aspect of circle of Willis. I showed you this last week in the last lecture, but we can make a review of this. A1 segment courses above the optic chiasm of nerves to join the anterior communicating artery. It is usually above the chiasm, 70% of brains, rather than above the optic nerves. These are some beautiful pictures. Optic nerves, anterior clinoid process, supraclinoid carotid artery, A1, and middle cerebral artery, temporal lobe, and frontal lobe. This is interhemispheric fissure, and here we can see the anterior communicating artery. This video I showed you. Hypoplastic, short and long anterior communicating arteries are also observed, as well as the presence of communication between both anterior cerebral arteries due to the union of their respective walls, but without the formation of a true anterior communicating artery. This is a very short anterior communicating artery and some branches coming from it. A1 segment send branches to the anterior perforated substance. Here is anterior perforated substance. Most of these arteries arise from the proximal half of A1. Hypoplastic, short and long anterior communicating arteries are also observed. And the absence of a true anterior communicating artery. Its importance lies on the number of perforating arteries. It originates with a range of 1 to 11 perforating arteries with a diameters between 500 or just under 100 microns. They irrigate lamina terminalis and hypothalamus, anterior commissure, septum pellucidum, parolfactory gyrus, subcallosal region, and genu of the corpus callosum. I dissect the gray substance of the frontal lobes, and we can see the A1 left side, A1 right side, anterior communicating artery, and some branches from A1 and A2. Middle cerebral arteries, lenticulostriates arteries, and perforating arteries. The microvascular anatomy of the anterior communicating artery shows great variability in its shape, diameter, and length. presenting fenestrations, duplications, triplication. The anterior communicating has an average length of 6 millimeters with a diameter of 0.8 to 4 millimeters. So here we have a basal and inferior aspect of a brain that was not injected to differentiate the Liliequist membrane. This is Liliequist membrane formed by arachnoid tissue. All of this is arachnoid. Here we have the basilar, P1, and we can see also posterior communicating arteries. But in order to study, to understand these arteries, is much better to inject those arteries. Here we have a fenestrated anterior communicating, the absence of a true communicating artery, and this is all. Thank you very much for your attention. Thank you.
Thank you. Thank you, Victor.
Ben.
Thank you for your very nice presentation, especially the deep located posterior part of the sulcus willis. Thank you.
Yes, I think this part of the brain is the most amazing, because the origin of numerous branches going to the posterior perforated substance. And we as brain surgeons know that it is maybe the most difficult area to approach, especially some aneurysms coming from basilar bifurcation.
Yes, exactly. Takashi, yeah.
This is Takashi Kon from Tokyo, Japan. Thank you for the nice presentations. Very fine, beautiful microanatomy. So we're very informative and very good material to learn for Japanese students, medical residents, our neurosurgeons. Thank you. So, as for microsurgical anatomy, so very important anatomy for our surgery. So this is a basic anatomy we should learn, reviewing several papers, and review again and again your lecture, and learn more, and for final to our project was surgical anatomy. Thank you for the nice presentation, and expecting for the next presentation. Thank you.
Thank you, Takashi.
Hi, good morning. Hi.
Go ahead, Radames, go ahead.
Hi, Professor. Good morning. Radames from Chiapas, Mexico. It's important. Sometimes when you are in operation, you realize that the anatomical variations are so frequently and are quite different. That's why this kind of image, this kind of job, that's a very difficult job, a very stunning job, are too important, because you realize what is the different variations you could have on one surgery. Congratulations, my master, Dr. Victor Hugo Perez, Hughes from Tuxtla Gutierrez, Chiapas.
Bienvenidos.
Thank you, Radames. Thank you. We hope to organize a course in the south of Mexico, in the southeast of Mexico. Chiapas is one of the most beautiful countries in Mexico, one of the most beautiful cities, communities in Mexico.
Yes, of course you're invited. On September, we have the National Congress of the Mexican Association of Spine Surgeons. So you are invited, of course.
Yeah,
and
like
Professor Victor Hugo Perez is one of the professors from that course.
Thank you. Thank you.
Great.
Very good.
Victor, I have a question because I noticed that you when you inject the color, it's a silicone glue.
Silicone rubber is
Okay.
rubber.
Silicone rubber, yes.
Silicone.
So
Yes.
so the pressure is quite high. So it looks that in your is it larger than the real size after your injection of the silicone rubber in the anatomy presentation, you know?
Yes, yes, Binshu. There is a special oil to dilute the rubber. So first I use dilute rubber in order to go to the very small branches.
Yeah.
And then I inject the other rubber that is not diluted. So that's the reason we can go through very small branches. Yes.
So it's the size of the small vessels is, I think it's bigger than in the real human being. Is it true? Because maybe the high pressure from your injection.
No, I think it's almost the same size, because you know, if I know that if I inject with a strong force, I disrupt, I break the vessel. So I think they are in the same size. Like if we inject those vessels in systole, in cardiac time of systole, you know.
But you know, in the real operation, we don't see so big size of the small perforators. Normally, it's smaller.
The size of these vessels, well, they are
especially the small ones, because you know,
yes,
most
of course,
them,
even even if, for example, if you have a ruptured aneurysm, and for example the brain is so injured, it's too damaged, it's swelling, sometimes you don't realize the difference between the arachnoid bands and the arteries. So it's difficult. Dr. Victor Perez said that this region is too difficult for me. All inside the brain is too difficult, no matter where it is. Sometimes subdural hematoma could be a mess, and middle cerebral artery aneurysms could be a mess. It don't need to be something in the tip of the basilar artery, for example.
Yes. These vessels are most of them less than 200 microns. So I inject also the spinal cord, and this is very, very difficult to inject. Sometimes I need to use a paint, like automotive paint, diluted with thinner, in order to go to the very, very small branches. But it is possible. It's a nice and a good question, Binshu. But I think the vessels could not go to be bigger, because you can break that arteries.
Okay, thank you.
Thank you to you.
Okay, Victor, any more comments or questions from the audience? So now, Jesse, I know it's not going to be a good answer, but were there any questions from the Chinese audience that asked you at all, Jesse?
Well, we haven't received any comments or questions.
Okay, it's not going to be easy, I know, but we'll continue to work at it. And I'd like to thank you, Victor. Let me just show you what you're talking about next week. You have, this week was arterial circular Willis. Next week is posterior cerebral artery, which will be presented at the same time, the same channel. Okay, Victor, any parting words?
No, thank you very much. Thank you very much. A great
Okay,
honor
we'll
to
see
be with all
you
of you.
next week, and thank you, Benzu, for setting it up, and thank you, Jesse, for translating, and we'll see you all next week.
Okay,
Adios.
thank you.